So, welcome to OCD, Recognizing and Treating in the Primary Care Setting. I'm Karen Koch, the Director of Mental Health Education at Eastern AHEC, and I want to welcome you to the webinar series. This is part of our Child Mental Health and Primary Care statewide project that is funded through NCAHEC. And this funding allows the series to be offered free to our participants from across the state. So without further ado, please let me introduce your speaker this evening. It's my pleasure to introduce Dr. Amanda Kimberg. She's a medical instructor in the Department of Psychiatry and Behavioral Science at Duke University School of Medicine. She received her medical degree from Duke and was selected for the Primary Care Leadership Track. That's a program that emphasizes training in outpatient settings and leadership development. So we're very pleased to have Dr. Kimberg with us this evening. Thank you for joining us.
Hi, everyone. Good evening. Thanks so much for joining. I'm really excited to be talking with you all about OCD tonight and recognizing and treating OCD in the primary care setting. So to start with disclosures, I have no financial affiliations or conflicts of interest to disclose. I want to start here with telling you a little story about pretty much the first patient I met and treated with OCD as part of my training. I did training in New York City in Manhattan at Mount Sinai Hospital in a combined pediatrics, adult psychiatry, and child psychiatry training program. And right about the middle of my training, at the beginning of my adult psychiatry rotation, I met a young woman, very young woman. She had just graduated from a college with a very fancy name a year before I met her. And after she graduated, she went into her room and basically just crashed and didn't come out of her room for about a year. Hardly showered. Her parents would bring her meals in, and she was just doing really horribly. A few months before I met her, her mom had finally been able to get her out of the house and to see their primary care doctor, who very quickly diagnosed her with depression and OCD and got her started on a really good dose of an SSRI. And by the time I met her 2 months after that, although she was still very symptomatic, her functioning had improved so much that she had gotten a job, got an apartment with friends, and had been able to set up an appointment to meet with me in my role as psychiatrist. So I then got to work with her over the next few years, and always like to give her credit because I feel like everything I've learned about OCD since then was built on the foundation of this patient. She also makes me so excited, and it makes me so excited to teach you about OCD because recognizing it and treating it can just have such a profound impact on patients' functioning and well-being. And although when I saw her, she'd already had so much improvement, being able to teach her about OCD and learn about OCD alongside her just helped remove layers and layers of shame that had built up over the years. And so I'm really excited to partner with you guys and teach you about OCD so you can also help your patients to have this sort of life-changing experience. So today, our learning objectives are that you'll be able to efficiently screen patients for OCD, initiate first-line treatment for OCD, and counsel families and patients about their diagnosis, prognosis, and treatment options for OCD. So what I want to do today is sort of take you along through a sort of patient encounter. So first, we'll talk a little bit about what an OCD patient might look like in your office, how you might recognize them or screen for them. Then I'm going to teach you a little bit about OCD in a way that you could share the same information with your patients as the first stage of treatment would be education. And then we'll talk about the second and third stages of treatment, therapy, and medications. So what might OCD look like when it walks into your office? Many of us have a bit of an idea what OCD is. Maybe we've seen it in TVs, in movies. And the image that comes to mind might be someone who's obsessively clean, washing their hands all the time, organizing things. But OCD can look quite different from that. And in children especially is often quite different from that sort of traditional idea. OCD is made up of a person having either obsessions or compulsions or both. Obsessions being ideas, intrusive thoughts that come into their head that are unwanted. And compulsions would be habits or rituals that a person feels compelled to perform. In children, most common obsessions includes the idea that something bad might happen to them or to a loved one. They also, some other common obsessions include illnesses and body sensations, religious obsessions, fears of contamination, sexual obsessions are common as well. And this one that's a bit harder to characterize, and we'll talk more about it, but a feeling that things need to be just right. Compulsions can look like practiced ways of washing hands, repeating certain rituals or behaviors, checking locks, checking doors, checking in with parents that everything is okay, ordering things, superstitious rituals, and avoidance can be a form of compulsion as well. One thing to know is that these symptoms wax and wane over time and they can morph. So what starts as one compulsion, maybe hand washing, over time might change into a totally different type of compulsion. And it's also important to note that functioning is impaired. So these children are going to have social problems. They may find themselves quite isolated from peers and even family at times, and maybe experiencing school difficulties. So just to help you picture what a patient with OCD might look like a little more, I'm going to go through two cases that are based loosely on patients I've worked with over time, to give you an idea what this might look like, how you might ask about OCD. So the first patient I'm going to introduce you to is a 12-year-old boy with known generalized anxiety disorder. He also has tic disorder, and he has difficulty completing his homework, which is the main complaint that came into my office. As I asked more questions about the difficulties completing his homework, I had ADHD on my mind. Maybe that's what was going on. That's pretty common. But I learned that he'd also stopped reading for fun. He used to love to read and would spend hours every afternoon reading, and now he just couldn't pick up a book. So as I dug deeper, I learned that he had started rereading phrases in his favorite books or even in new books. He would read the same 3 or 4 words, the same 2 or 3 sentences over and over and over again until it felt just right. His mom thought this was a tic, given that he had a known history of a tic disorder. And so one thing I want to point out with this case is just how hard it can be to tease out whether a repetitive behavior is a tic or whether it is a compulsion that's part of OCD. In this case, it turned out to be a compulsion related to OCD, and the obsessive counterpart was the sense that it just needed to be right. So as he was reading, he had a feeling of being ill at ease, and he would read it over and over and over until it felt just right, and then he could move on. But that became so overwhelming and distressing that he completely stopped reading. As this boy got older, things began to change. So at age 13, he began to develop excessive hand washing. He would use a bottle of soap a day. At age 14, he started checking with his mother frequently about somatic complaints. So a headache, he would ask her dozens of times, could he have a brain aneurysm, a stomach ache? He might be worried about a vomiting illness that might come. And then when he was even older, at age 16, his mom reported to me that he had stopped showering. And as I learned more, he was still showering once or twice a week. But on those days that he did shower, he had an elaborate ritual for how he showered that would take up to 2 hours. And when he finished, he was just exhausted. And so therefore, he was avoiding showering because when he did shower, it was so overwhelming and intense. When I tried to ask him about particularly obsessions that might be linked to these behaviors, thoughts that might be associated, he could tell me nothing. And what I want to point out here is that there's a lot of shame around the obsessive thoughts that people have, the intrusive thoughts that children have, and they'll go to great lengths to hide those obsessions at times. I also want to point out here that what a compulsion a child might have when they're younger will change over time. And so for him, it started as rereading and checking. Later, he had hand washing rituals. Later, checking in about his body. And then when he was older, again, back to some of those grooming rituals. So in OCD, the habits, the rituals we see shift over time. And now I'm just going to tell you about a second case. This one is maybe less typical. So this was but also common. This is a case of a 16-year-old boy who was first admitted to an inpatient psychiatric hospital for depression. And while he was there, he disclosed obsessive thoughts that he might be a pedophile. When he'd have these intrusive thoughts, they would lead him to avoid contact with his younger siblings. So he would leave the room and go isolate into a space by himself. He didn't have any prior history of any sexually inappropriate behavior, and he didn't have any intent or desire to act on these thoughts. He was mortified by the thoughts and would go to great lengths to get rid of the thoughts when he had them. So one thing I want to point out here is that in obsessive compulsive disorder, the obsessions are ego dystonic, meaning that they're disturbing to the patient, and the patient might find them unusual and even foreign to them, and they have no intent or desire to act on the thoughts. So the thoughts that a patient with OCD has are typically not a safety concern, although they require careful screening and often co-managing with a mental health professional in this type of scenario. Sexual obsessions are quite common, but don't prevent a safety risk to those involved. So those are just a couple examples of patients that you could encounter with OCD who might come into your office. OCD is quite common, as we'll talk about later. It presents in about 1% to 2% of children. And so you want to have this on your mind anytime you're meeting a child who presents with anxiety or repetitive behaviors. Unfortunately, there's not really a fantastic screening tool that you can use with all your patients, but here are a few questions you might consider asking when you see a patient with anxiety or repetitive behaviors. You can ask, do you have worries that just won't go away? Do you have worries about things not being clean? Or do you worry that something bad might happen to you or someone you love? You want to also ask about the compulsions. Do you do things over and over or have habits you just can't stop? If patients are screening yes to some of these questions, then you might start to consider working up and diagnosing OCD. So OCD, the assessment and diagnosis of OCD is a clinical assessment. Here you'll see the DSM-5 criteria. So a patient just needs to have either obsessions or compulsions, or in many cases both, to be diagnosed with OCD. Obsessions are defined as recurrent and persistent thoughts, urges, or images that are experienced as intrusive and, importantly, unwanted and cause anxiety or distress. And the individual tries to ignore them, suppress them, or neutralize them. Compulsions are repetitive behaviors or mental acts that the individual feels driven to perform in response to an obsession or according to rigidly applied rules. The goal is to reduce the anxiety or distress or prevent a dreaded situation. Now, most of us have some intrusive thoughts and some habits that are important to us. That doesn't mean we all have OCD. To diagnose OCD as well. So these obsessions or compulsions must be time-consuming or cause significant distress to the patient. As you're diagnosing, well, I wanted you to know here that there is a gold standard tool used to diagnose and determine severity of OCD. This is called the CY box, which stands for the Children's Yale Brown Obsessive Compulsive Scale. And this scale is used in research and clinical settings to make a formal diagnosis and to determine severity of OCD. It's extremely time intensive, can take 2 or 3 hours to complete, but I did want you just to be aware of it, although it's not practical to use in primary care setting or even in an outpatient child psychiatry clinic setting in many cases. It starts with a checklist that goes through all of the most common obsessions and compulsions. So you'll see here, I just included a screenshot of a few of the obsessions, but there's about 2 pages worth of checklists that you go through with the patient to see if they have any of these obsessions. Then there are a series of about 12 questions that determine the severity of the obsessions and the compulsions, and the patient would receive a score that can be used to track response to treatment over time. Again, totally primary care setting, but a helpful tool to know about in case you ever wanted to look up some common symptoms or have an idea of how this tool is used in research in some clinical settings. Of course, when you're diagnosing, you want to consider your differential. So normal development. Of course, we know 2-year-olds like to line up their toys obsessively, and 7-year-olds are really need the rules of the game to be just right. And so we just want to keep in mind that obsessive and compulsive traits can be normal development at different stages of development. Autism spectrum disorder can often is also on the differential for OCD. So children with autism can also be quite rigid at times and have repetitive behaviors. And so this is an important differential to consider and can be comorbid with OCD as well. And psychosis and tics are also on the differential and need to be considered when you're considering a diagnosis of OCD. So after you've made a diagnosis of OCD, it's time to start treatment. And the first step of treatment is education, helping your patient understand what OCD is, how they came to have it, and what to do about it can make a huge difference in their functioning and reduce the shame associated with OCD. So I'm gonna teach you just a little bit about some of the things we understand about OCD. And this is all information that might also be helpful to share with your patients during that first phase of treatment where you're providing education. So where does OCD come from? Why do I have OCD? The patient might ask. So OCD, we understand, comes from a combination of genetics and environment. So many patients with OCD will also have a first-degree relative with OCD. And then there are certain environmental factors, particularly around perinatal stress, that can also contribute to OCD. On a neurotransmitter level, we know that serotonin and glutamate and dopamine are involved. And we basically know this because the medications that affect these transporter systems are the medications that are most helpful for OCD. We also know that OCD is a connectivity issue between neural circuits. So some of the pathways that connect the cortical basal ganglia circuits and the frontal amygdala circuits are impaired in OCD. Just to say a little about the epidemiology as well, the prevalence of pediatric OCD in the US is about 1 to 2%, so it's quite common. It peaks in pre-adolescence and again later in young adult life. It's a bit more common in males than females, especially in the pediatric population, and there's a delay in diagnosis. So children will often have experienced symptoms for several years before they present to care. It's also comorbid with many conditions, and the patients you meet who have OCD will often have other disorders such as ADHD, other anxiety disorders, tic disorders, and mood disorders. Okay, so how might you explain this to a patient? So I'm going to try just to sort of imagine for a minute that I'm speaking to a patient and I'm sharing with them their diagnosis of OCD and how I might share that. So imagine along with me that I'm sitting here talking with a patient and I'm going to model a little bit how that conversation might go. Okay. All right. So thank you so much for answering all these questions for me and speaking with me about what's been going on with you. I want to share a little bit about what I think may be causing some of your problems, if that's okay with you and if you're ready for that information. Okay. Well, I think that I understand that you have something called OCD, obsessive compulsive disorder. And what that means is that sometimes thoughts pop into your mind that you really don't want there, and you don't understand how they got there. And other times you feel like you just have to do things that don't make a lot of sense, even though maybe you don't really want to do them. One thing I know about how this came to be is that this isn't your fault. You didn't do anything to get OCD. What I do know is that there are some problems with the connections in your brain that are making this problem for you. So I think about there being two parts of the brain, one part in the back and one part in the front that we're going to talk about today. So the back of the brain, it tells you when there's a problem or when you're in danger. And it sends a message up to the front of your brain. And the front of the brain kind of checks around to see if things are safe and to see if there's a problem. And most of the time, things are okay and pretty safe. So it sends a message back and says, everything's fine, you can calm down now. But that connection isn't working very well for you. So it might feel like your brain is just screaming at you all the time that there's a big problem and that you have to do something about it. Okay? What I want to tell you is that there are some things we can do to help improve that connection. We can use medicines and we can use therapy to rebuild that connection and strengthen it so that your brain doesn't feel like it's screaming at you all the time. And I'm going to partner with you and work with you as we take those next steps. One last thing I want you to know about OCD is that it is common, and you've probably even met some other kids who have it before. And if you haven't yet, you will one day. This is a common issue that children face, and it can get better, and we're going to start working together to help you get better. Okay, so thanks for bearing with my little one-person role play, but I wanted to model for you how you might try to use this information about the pathophysiology of OCD and the epidemiology of OCD to start to teach your patients about what's going on as the first step of treatment. So now let's talk about the second step of treatment. So we get a lot of information about how to treat OCD from this landmark study, the POT study, which was completed in 2004. So this was a randomized controlled trial that compared 4 groups: a placebo group, a group that received sertraline, a group that received cognitive behavioral therapy, and a combined treatment group. And the outcome of the study demonstrated that combined treatment had improved outcomes compared to CBT. CBT and SSRIs were pretty similar at the 12-week follow-up point, but when the study was followed out more longitudinally, CBT outperforms SSRIs, and both were significantly more efficacious than placebo. So this study leads us to initiate treatment in a multimodal format, starting with typically SSRIs and therapy as first-line treatment when both are available. So let's talk about what those two types of treatments look like. So therapy for OCD is a very specific type of cognitive behavioral therapy known as exposure and response prevention. This is a time-limited therapy, typically 12 to 20 weekly sessions. It starts with what we just discussed, so psychoeducation about OCD, treating the child and the family about what OCD is. I included a link here to the OCD Foundation, the International OCD Foundation, which has a ton of wonderful resources about how to talk with children about OCD and families. And I'd encourage you to check it out if you want to learn more. The goal of the first stages of therapy are to improve a sense of control. And also, as you progress through therapy, the goal is to learn how to tolerate distress and uncertainty. I'm going to show you a little bit more about what this type of therapy might look like. So the idea here, here we have an anxiety curve looking at when you use an exposure, when you apply an exposure of a fear trigger. And then over time, anxiety will increase and peak and then come back down. Anxiety always goes up and comes down when we are exposed to a feared stimulus. The idea here is that over time, the more you expose someone to their feared stimulants, they will move from the red curve down to the blue curve. So their peak level of distress and anxiety will come down, and the amount of time that it takes them to come down from that peak will start to shorten over time. So with that idea in mind, the way that exposure therapy works is that you gradually introduce children to their feared exposure. So you work with a child. The example I used here would be a sort of made up example for a kid who might be worried that their obsessive thought might be that harm will come to their parent. And they have a lot of rituals around things that they do to prevent harm coming to their parent. Maybe they can't step on certain parts of the floor. Maybe they have to say, I love you each time they step away from their parent. There are certain words that they can't say around their parent because they feel like their behaviors could lead to some harm coming to their parent. So here's a pretend fear hierarchy you might develop with a child. So working with them, thinking about how different behaviors would cause them distress, and then assigning those behaviors a level of distress from 1 to 10. So maybe asking the child to just say the word die would lead to a level 5 distress. Reading a fairy tale about parents who die would lead to a level 6 distress. Writing their own story would lead to a level 7 distress. And then so on, coming up with behaviors that are increasingly distressing. The child would then practice doing each of these feared things in the office with the therapist, and then they'd go home and practice them at home with the family. So they'd have homework between each session. And over time, as they practice the behavior over and over, the expectation is the anxiety should come down and down and down. And they're able to avoid fewer things in their life that cause them this anxiety and distress. So in addition to therapy, medications are quite effective as well. While therapy is recommended as first-line therapy, there may be patients who have so much distress that they're not ready for therapy, or they might not have access to therapy in the community where they live. And in this case, it would be absolutely reasonable to get a kid started on an SSRI right away. A couple things that I do want you to know about treating OCD with SSRIs are that higher doses are sometimes needed, are often needed, and length of time to treatment response is longer than for anxiety and depression. So what that means is before deciding a trial of a medication is ineffective, you'd want to wait a full 12 weeks, including 3 weeks at the highest dose. So for example, that would be 200 milligrams of sertraline for 3 weeks before you would call it an ineffective trial, or 60 milligrams of fluoxetine before you would call it an ineffective trial. Okay. Fluoxetine and sertraline are the 2 medications that are FDA approved for treatment of OCD. And these would be the medications you would start with and use to treat OCD. Here I have the treatment ranges and the titration schedule here for you, just for your reference. And these would be the only 2 medications you would be likely to be starting in primary care setting. I did want to point out that there is another SSRI that is FDA approved for treatment of OCD, and that is fluvoxamine, or known as Luvox. That's its trade name. This medication is a little bit less familiar to us in primary care and comes with some increased side effects and drug interactions, and so would be most likely a tool that would be used by a mental health professional. And clomipramine is a tricyclic antidepressant. Again, many more drug interactions and side effects, so most likely to be used by a mental health professional. But these are both medications that also have FDA approval for OCD. Furthermore, you could be treating a patient for OCD and you're co-managing them with a mental health professional. It would be reasonable in that setting to use a second-generation antipsychotic to augment an SSRI when there's partial effectiveness. again, another tool that would be sort of in the mental health professional domain, but you could encounter patients who are on these medications. So I just wanted to point out that that would be a reasonable treatment modality in some cases. Yeah. So I also wanted to take a minute to make a note about PANDAS and PANS. This topic can come up in primary care and could give a whole nother presentation about it, or a whole class. But I want to just make a few points about PANDAS as part of this talk. So I imagine that when OCD is diagnosed in primary care, there can often be some questions about what caused this. Could it have been a strep infection? Could this be PANDAS? So there's a lot of controversy around this diagnosis, but a few things we do know is that pediatric autoimmune neuropsychiatric syndrome is characterized by a sudden onset of tics and OCD symptoms. So you'll often hear about a child who was functioning really well and then almost overnight started to develop a number of OCD type symptoms and some neurological symptoms as well. The workup includes a little bit of lab tests. So you would want to get a strep test, an ASO titer, mycoplasma titers, CRP, and CBC if you are concerned about PANDAS. If you're making the diagnosis of PANDAS, treatment is fairly straightforward. You're going to treat any active infection just as you would if they had strep. If they have strep, you'll treat it. If there's an active infection, you'll treat it. And you'll also treat the OCD. So you'll treat the OCD just the way you would if it was standard OCD. So with SSRIs and CBT. And if in most cases, children will respond and show improvement. Routine antibiotic prophylaxis or immunotherapy is not indicated in children with PANDAS. And if they're not showing response to standard treatment pretty quickly, then you'd want to consider referral to rheumatology and psychiatry to co-manage a patient with PANDAS. Okay. I have some references here, and then one last thing I want to point out is that it's always okay to ask for help. And in North Carolina, here in North Carolina, we have the North Carolina Psychiatric Access Line, NCPAL, which is staffed by a behavioral health consultant and child and adolescent psychiatrist or mental health professional every Monday through Friday, 8 to 5 p.m. And your calls are welcome. And we would love to support you in managing these patients in the primary care setting. So the way the line works is you just give a call to this number, 919-681-2909, and you press 1 to speak to a child psychiatrist. The behavioral health consultant will answer the phone and collect some patient information and help you sort out what your needs are. So if you need some help with finding therapists in the community or supports, that is certainly something we can help with. And then if you need some help with medication management or diagnostic clarity, you'll get a call back quickly from one of our child and adolescent psychiatrists or pediatric mental health specialists to help you sort through those questions about medications and diagnosis. Again, here's our information, and please reach out anytime. Or if you have any questions about the NCPAL line, you can email as well. The email address is here at the bottom. It looks like we might have a question here, and I will stop here and answer whatever questions you have.
Thank you, Dr. Kimberg. We do have a question. The question is, do you see any utility with an additional diagnosis of OCD for someone with autism spectrum disorder?
Yeah, that's a great question. So some of the features of autism that we discussed before, some of the repetitive behaviors and restricted interests are going to be treated with tools like ABA therapy. But if a child also has OCD, comorbid OCD, that would be a very different treatment approach. including SSRIs, and depending on the child's ability to engage in therapy, CBT therapy in many cases. And so absolutely trying to clarify that diagnosis and make both diagnoses when it's indicated so that you can treat both comorbid conditions is going to help improve the child's functioning and reduce their symptom burden.
Thank you, Dr. Kimberg. How do you handle behaviors in the classroom with a student who is on the spectrum that can be dangerous to the other kids in the classroom?
Yeah, wow, that's a tough question to that's a tough situation. So a kid who's on the spectrum and having dangerous behaviors, a couple of things come to mind. One, making sure that they have all the appropriate academic support. So making sure that the child has an IEP or 504 plan and that all the supports they need to be safe in the classroom are in place and are happening in the school setting. If there's a safety issue in the classroom, then this child probably also warrants an evaluation from a mental health professional as well to determine if there are other comorbid conditions going on that could be treated to reduce the aggression and improve safety. So maybe this child also has ADHD that could be treated. We want to make sure we're not missing any trauma or any other possible comorbidities that could be contributing to the aggression as well. Again, this type of patient situation. We actually get calls for quite often on the NC PAL line, and we would be more than happy to sort of support you through thinking through a patient like this and how to best support them.
We do have another question. Since OCD tends to run in families, wouldn't learning play a role? Obsessive cleaners, for example, moms do teach their beliefs.
Yeah, absolutely. So there can be a component of environment and genetics, absolutely. And I'll say the other piece of this is it can be really hard to engage in the therapy part of treatment for parents who have undiagnosed or untreated OCD. So when we're asking parents to expose their children to stressful stimuli, if that stress is also really a big stressor for the parents, that can make it really challenging to treat. And so often part of the education for the families is helping the families also recognize their mental health needs and accessing the right treatment for them as well.
Thank you. There is a follow-up question, sorry, I didn't see it, to the question regarding the behaviors in the classroom with the student. Apparently, this particular patient is seeing a doctor with prescribed meds. He's having OCD behaviors of digging in his pants multiple times daily, then putting his fingers in his mouth and touching everything. Any thoughts about that?
Yeah, this sounds really like a difficult case. It's hard for me to tell from this description alone what is the function of the digging in the pants and whether it's an OCD behavior or whether it's a sensory or a stimulation behavior related to autism. I think that this would require a little bit more information and a little bit more back and forth to discuss. But again, this sounds just really like a tough case and a really good one to call in, even if the patient's already seeing another ND. If there's still some concerns and you're needing support around how to best support this family, certainly I will welcome you to call the NC PAL line so we could help get really into the details and think about how to best support this kid.
And I also wonder if this particular child is being seen through the UNC Teach program. They may have some other additional resources to offer this child and family.
Yeah, great point.
It looks like we have another question. Well, actually a comment that to you, Wendy, that they would rule out GI.
Yeah. That's a great point too, right? This is so complex to understand what the trigger is. Could this kid have constipation? Could he have pinworms that's causing him to scratch? Right, there's just so many factors that could be at play contributing to this really difficult behavior.
We also have a question about medication. How do you titrate up sertraline to treat OCD? How long should you wait between dose changes?
Yeah, great question. So I'm going to see if I can go back to that slide. So your starting dose is going to be a little bit different based on age. So for a child younger than 12, you might start at a dose of 12.5. If they're older than 12, you might start at 25. And then you're going to increase at increments of, then depending on how well they tolerate the medication, will guide how quickly you titrate up. So typically you're going to want to go up by 25 milligrams about every 2 weeks, give or take. If patients having side effects, you might slow down the titration or go by smaller increments, maybe going up by 12.5 milligrams at a time. If they're not having any side effects and they're just doing fine with the medicine, then you might go a bit faster with your titration. And you're going to be aiming for remission of symptoms. So for improvement in functioning, getting back to school, getting back to whatever it was in their life that had kind of become restricted. And so that may mean you're getting up to a dose of 100 milligrams, 150, even 200 milligrams. So you're going to keep going up on the dose until you either have intolerable side effects or until you have remission of symptoms.
Thank you so much. There is a suggestion, Wendy, as well about your students and their inappropriate behaviors, maybe providing alternative smelling alternatives, scented lotion on the wrist, etc. This does sound like a really good case for NC PALS and/or Teach. Really be able to sit down and talk with you about this particular case. It sounds pretty darn challenging for sure. We do want to thank you, Dr. Kimberg, for your information and for being with us this evening. Thank you so much. It was excellent information, and we had some great questions as well.